I appreciate the opportunity to talk to you all today. I'm going to discuss the evaluation of the cardiac and pulmonary risk in the pre-op patient. I'm Adam Schaefer. I'm a hospitalist at Brigham and Women's Hospital and an assistant professor of medicine part-time at HMS. And I have no conflicts of interest to declare. So first, just thinking about the role of the clinician in performing preoperative evaluation. The role should not be to provide medical clearance prior to surgery. I think that's sort of an unfortunate term that's sort of entered the medical the periop lexicon, because we're never really in a position to warranty that it's going to be clear sailing for any given preoperative patient. So rather than provide clearance, what our role should be is we want to assess the patient's cardiac risk and other risks going into the procedure, decide whether additional preoperative testing, such as a cardiac stress test, is indicated. When indicated, we want to recommend any pharmacologic measures to reduce preoperative risk, such as use of beta blockers or statins. And this last point here, I actually want to especially emphasize, assist the surgeon in deciding whether or not to go forward with the procedure. One of the things I sometimes see done, I think, suboptimally in preoperative medicine is losing the forest for the trees. So we want to think about, do we want to start a beta blocker? Do we want to start a statin? Do we need a stress test? But we also want to step back and consider, do the benefits of this surgery outweigh the risks for the patient? And I think as the medical consultant, we're in a particularly good role to step back and consider that issue. So to start, I'm going to discuss the 2014 ACC/AHA guidelines on perioperative cardiovascular evaluation. These are the guidelines everyone uses, so they really sort of define the standard of care when it comes to preoperative evaluation and perioperative management of patients. So I'm going to start by giving you, here's the 30,000-foot view. Many of you may be familiar with these guidelines, but I'm going to take a few minutes just to walk you through the key components for those of you who may be less familiar. So as a first step, we're going to determine if the patient is undergoing emergency surgery, then of course you have the patient undergo the procedure and you do the best you can to mitigate any risks that have been identified. And if a patient is having an acute coronary syndrome, generally you're going to want to put the brakes on surgery, probably formally involve cardiology, and that ACS is going to need to be managed. But the vast majority of patients who will be seeing as the perioperative consultant, it'll be a non-emergency case, and there won't be any acute coronary syndrome or any active cardiac conditions that will preclude surgery. So most of the patients will fall into the category of being non-emergency and non-ACS. So for the majority of patients for whom that is the case, the first question we need to ask is, what is their MACE risk? So the MACE risk refers to the risk of a major adverse cardiac event, which is defined as either death or MI. And of course, the MACE risk is a function of both the patient-specific risks and the procedure-specific risks. And if there is a low risk of MACE, which is defined as a MACE risk less than 1%, then one's going to generally go to surgery without any further cardiac testing. If your MACE risk is greater than 1%, which puts you at elevated risk, then as a next step, as we'll talk about, you're going to want to consider the functional status of the patient. But first, we're going to discuss what are the tools at our disposal to quantify a patient's MACE risk. So there are three tools that are available. The first two are online calculators, and that's really where things have evolved, such that almost all of us use the online calculators to obtain a very specific quantitative MACE risk. There's also the RCRI score, which I'll mention briefly, which is a set of risk factors. But the RCRI score is sort of older, and the two perioperative online calculators outperform it. So most of us use one of the calculators predominantly. So my personal favorite is the NSQIP surgical risk calculator, and you see a screenshot here of the information inputs that are used with the NSQIP calculator. So it may look like there's a lot of fields here and a lot of information to put in. As someone who uses it a lot, it doesn't take very long to put in this information. This is all very sort of basic clinical information. And if you don't have some of this information, that's okay too. I typically don't put in BMI because I often don't have that at my fingertips. One thing which isn't in the screenshot, which I should mention, in addition to this information on the patient, One also puts in information. There's a list of what procedures, and you pick what is the surgical procedure the patient is undergoing. And once you input that information, what you get as output is seen here. So first I want to highlight the right here, the risk of cardiac complication. This corresponds to the MACE risk. So one of your first questions is there MACE risk greater than or less than 1%? And this category here, cardiac complications, is the MACE risk. So that's usually the first thing that you hone in on. But one of the reasons I am generally a fan of the NSQIP calculator is it gives you the risk of not just MACE, but it gives you the risk in multiple other domains. You can see here, you get the risk of serious complications, any complications, you get the risk of pulmonary complications such as pneumonia, and you also get a risk of death. And I find it very helpful to sort of zoom out and think about the risk in all the domains, because one of the mistakes I see commonly when I see preoperative evaluations performed is getting on blinders and only focusing on the cardiac risk. Because I like to say a little bit sort of cynically that non-cardiac death is still death. So one needs to consider the mortality risks for the patient, not just of cardiac complications, but also of other complications. And this calculator does a good job of providing you information on an array of different clinically relevant risks to the patient. So here we see one of the other cardiac MACE calculators, often called the Gupta calculator, after the authorship of the paper that generated this. And there's less information that you put in on this calculator. You just get, as you see, age, creatinine, ASA class, and their functional status, and then the procedure. That also gives you less information output. So it just gives you the risk of perioperative MI or cardiac arrest. So it just gives you the MACE risk. It doesn't give you the risk in other domains, as does the NSQIP calculator. And here you see the RCRI, which lists six different risk factors that put you at increased risk of adverse perioperative events. In general, once you have an RCRI score of 2 or more, that corresponds to an elevated MACE risk. But there has been some recent literature that has compared the performance of the RCRI to the online calculators, and most of that literature suggests that the online calculators outperform the RCRI. So I still have the RCRI in my mind in the background as sort of a rule of thumb to give me sort of a quick and dirty sense of what the patient's risk is. But when I'm actually deciding how to clinically proceed or go forward, I'll usually use the NSQIP calculator as the dispositive mechanism of assessing MACE risk. So as we talked about, you get your MACE risk, and if your MACE risk is low risk, so less than 1%, then generally you're going to want to go forward with surgery without additional testing. However, if your MACE risk is greater than 1%, which puts you at elevated risk, then you're going to want to consider the patient's functional capacity. So functional capacity is measured in METs. Most of you are probably generally sort of familiar with what degree of physical activity corresponds with how many METs. But a typical scenario is, can you walk up a flight of stairs carrying a bag of groceries? If you can do that, generally you're going to exceed the 4 METs threshold. That will generally have you go forward with surgery, even if your MACE risk is greater than 1%. If you're able to sort of do a good job cleaning your home and do basic and moderate housework, that will also generally put you above 4 METs. And to step back, the reason we care about your METs and your functional capacity, the way I think about it is it's basically a poor man's stress test. That you're saying, can you walk up 2 flights of stairs without any cardiac symptoms? If you do, that puts you at lower risk for having clinically significant CAD, and that makes us more comfortable with going forward with surgery. I want to emphasize when you're asking about someone's functional capacity, you're asking about that in the absence of cardiac symptoms. So can you walk up 2 flights of stairs carrying a bag of groceries without chest pain or without major dyspnea? So now we're going to turn our attention to some of the pharmacologic interventions that are available to reduce perioperative risk. And the first one we're going to talk about is beta blockers. So beta blockers do appear to be of benefit in selected patients who are at elevated risk of perioperative cardiac events. Sort of keep it simple, if there's one thing you're going to remember about beta blockers, it's the class 1 indication for beta blockers. which is very simply that if you're on a beta blocker going into surgery, you want to continue patient on that beta blocker perioperatively. That seems simple, though in my clinical experience, certainly the beta blocker that the patient may have been on as an outpatient, sometimes those fall off in the hospital. So, being careful about that and making sure that the beta blocker the patient is on as an outpatient is continued during the perioperative setting, is important. And I also want to clarify that when we say we want to continue the beta blockers to run on the outpatient in the perioperative setting, it doesn't necessarily have to be the exact same beta blocker. Sometimes for various reasons, we'll move to shorter acting beta blockers, in the hospital with hold parameters. But the bottom line is if they're beta blocked as an outpatient, you want to make sure that that beta blockade is continued in the perioperative setting because beta blocker withdrawal can be dangerous, especially in the setting of the increased adrenergic tone that occurs around the time of surgery. So having said that, that provides us clear guidance about what we do with patients who are on beta blockers as an outpatient. And patients who aren't on beta blockers, it's not really settled exactly what we should be doing, although I'll talk about some of the data that is available. So the predominant large prospective randomized controlled trial of perioperative beta blockers to reduce perioperative risk was the POISE trial, the perioperative ischemic evaluation trial. This trial enrolled about 8,400 patients who were undergoing non-cardiac surgery who had at least one cardiac risk factor. So we generally consider these to be intermediate risk patients. In these patients, all of whom were beta blocker naive, so none of these patients were on beta blockers going into it, they were randomized to either placebo or controlled release metoprolol. 100 milligrams was given a few hours before surgery. A dose was given immediately post-operative based on their heart rate. And then the patients got 200 milligrams of the controlled release metoprolol daily for the 30 days post-op. So the primary endpoint, which was 30-day cardiac events, the primary endpoint was lower in the beta blocker group compared to the placebo group. The rate of 30-day cardiac events was 5.8% in the beta blocker arm versus almost 7% in the placebo arm, and that difference was clinically significant, or was, I should say, statistically significant. However, and this was the big rub of the trial, and why this trial caused a significant amount of consternation for those of us who spend a lot of our time in periop land, is the mortality rate was higher in the beta blocker group compared to the placebo group. And that increased mortality rate in the beta blocker group seems to have been driven to a large degree by the increased rate of stroke. So the stroke rate in the beta blocker group was almost twice that of the placebo group. And some of you may already have intuited some of the reason for that, which is, when you hear about the details of this trial, taking patients who are beta blocker naive and having them on 200 milligrams of toprol daily, that's a lot of beta blocker for patients who haven't seen beta blockers before. And that seems to have been the issue with this trial, that yes, that large dose of beta blockers had a significant anti-ischemic effect, but it also had some adverse effects in terms of dropping their blood pressure and causing ischemic strokes, and that drove the increase in mortality rate. So, as I said, the general view of this trial is that the dose of the perioperative beta blockers given was probably excessively large, and so led to an increase in the stroke rate. So the bottom line from this trial is giving high doses of beta blockers without dose titration to beta blocker naive patients right before surgery increases mortality. A lot of you have probably some important questions arising from this trial, and these are some significant questions which unfortunately we don't have good data to answer, which are, what if we gave moderate dose beta blockers? And what if we gave those moderate dose beta blockers, let's say, a week or maybe even a month before surgery, ideally titrated them up to our goal heart rate and blood pressure? In that setting, if I had to guess, I think there's a good chance the net effect of beta blockers would be positive, but we unfortunately don't have good prospective RCT data to answer these questions. So we do have some retrospective data, which I want to briefly mention. So there was a large retrospective cohort study that examined the benefits of perioperative beta blockers stratified by the cardiac risk of the patient. So patients were undergoing non-cardiac surgery, predominantly orthopedic and abdominal surgeries. And if patients were on beta blockers going into surgery and right after surgery, they were considered to be on prophylactic beta blockers. And those patients were compared to propensity matched patients who weren't on beta blockers. This study was very large, had almost 700,000 patients. However, they didn't do individual chart review. They basically classified them as being on beta blockers if the patients were basically on beta blockers at the time of surgery. So what we see here, and I'm going to sort of try to walk us through, is what this is telling us, because I think there's an important take-home message from this study. So we can see here the x-axis is the odds ratio for death in the hospital. So to the left here, that's a reduced risk of death in the hospital. And then they stratified them by their RCRI score. We mentioned the RCRI score before. So as you go down and get a higher RCRI score, your perioperative cardiac risk goes up. And what we're seeing here is a comparison for odds ratio for death in the hospital for patients who are on beta blockers compared to patients who weren't on beta blockers, stratified by their cardiac risk. And as you can see here, as your RCRI score goes up, so as your risk goes up, your odds ratio for death in the hospital goes down. So, this certainly suggests, albeit with retrospective data, that that there are patients who are at higher cardiac risk for whom being on perioperative beta blockers is likely to be beneficial. So as your RCRI score goes up, the benefit from beta blockers increases, and beta blockers confer a mortality benefit with an RCRI score greater than or equal to 3. So what do the ACC/HA guidelines give us in terms of recommendations? They mostly give us 2B recommendations about when to start beta blockers, which are sort of the less helpful, could consider type recommendations. So in patients with an RCRI score of 3 or more, it says it may be reasonable to begin beta blockers prior to surgery. And in patients with a compelling long-term indication for beta blockers, but no RCRI risk factors, initiating beta blockers is of uncertain benefit. So we really don't know what to do with those patients. There is a class 3 recommendation that I want to highlight, which is beta blocker therapy should not be started on the day of surgery. And that is based on the POISE data that we reviewed a few slides ago that said starting certainly high dose beta blockers within 24 hours of surgery resulted in increased mortality. So we don't want to be starting beta blockers on the day of surgery or within 24 hours of surgery. So those are where we are with beta blockers. But as I said, if you remember one thing, it's that class 1 indication for beta blockers, which is if they're on a beta blocker as an outpatient, you want to make sure that you continue the patient on beta blockers perioperatively. So now I'm going to turn our attention to statins. I feel like statins get somewhat less attention when it comes to their value in perioperative cardiac risk reduction, but that really shouldn't be the case because statins are an important tool in our armamentarium to reduce perioperative cardiac risk. So one of the prominent studies here I'm going to mention briefly is the DECREASE-3 trial, and this enrolled 500 patients who were at least age 40 who were at elevated cardiac risk who were scheduled to undergo non-cardiac vascular surgery. All patients had to be statin naive, and all patients were on beta blockers. So if you were on a beta blocker, they continued you on a beta blocker. If you weren't on a beta blocker, you were started on a beta blocker. But the point was they wanted all patients on a beta blocker so that there was no difference in beta blocker usage between the placebo group and the statin group. So patients were randomized to fluvastatin 80 milligrams daily or placebo. The statin was started 30 days prior to surgery and was continued for at least 30 days after surgery. A question I commonly get, so I will address it proactively, is why fluvastatin? Because fluvastatin is not a statin that we commonly use. The reason they picked fluvastatin, which is actually, it's only a moderate potency statin, the appeal of fluvastatin for the folks who ran this trial was that it has among the longest half-lives of any of the statins. And there's a little bit of data that statin withdrawal may be problematic. So the reason they used fluvastatin is they wanted a long half-life so the patients would continue to have statins in their system, even if they're NPO for a day or so. So that was the reason for fluvastatin. That said, I think most of us consider the effects here seen with fluvastatin as to be a class effect. So I don't think there's any magic to fluvastatin. So when we look at the effect of the statin compared to the placebo, the primary outcome was perioperative myocardial ischemia. And the rate was significantly lower in the statin arm, about 11% in the statin arm compared to 19% in the placebo arm, which is impressive. But perioperative myocardial ischemia is a little bit of a soft outcome. One of the reasons this study is fairly prominent is not only did it show a benefit for the primary outcome of perioperative MI, it also showed a benefit to statins for the secondary endpoint, but harder endpoint of perioperative death from a cardiovascular cause or MI. So statins about halve the rate of this outcome from 10% in the placebo arm to about 4.8% in the statin arm. So really overall, a pretty impressive benefit from statins. Full disclosure, there's a little bit of an asterisk to this trial because one of the people who ran this trial was fired for academic misconduct. So that's put a little bit of a cloud over this trial. The New England Journal has stood by this trial and has stood by the integrity of this trial. And as we'll see here, the benefit to statins in the perioperative setting isn't based on this trial alone. This was a meta-analysis that was performed in 2015 that looked at multiple trials. And the meta-analysis that encompassed this large number of statin trials found a mortality and perioperative mortality benefit to statins overall. So in this meta-analysis, periop statins significantly reduced all-cause mortality, and you can see the odds ratio of 0.54 is an impressive magnitude of an effect. And you can see there with the with the significant p-value, and you can see the odds ratio doesn't come that close to crossing 1. So I would say both a clinically significant and a statistically significant benefit to statins perioperative on all-cause mortality based on the results from this meta-analysis. So what are the recommendations from the ACC and the AHA for statin use? To try to make sort of conceptualizing all of this easier, it can be helpful to think about the parallelisms between beta blocker usage and statin usage. So the class 1 indication for use of statins perioperatively really mirrors the class 1 indication for beta blockers, which is if a patient's on a statin, as an outpatient, you want to make sure that you continue that statin in the perioperative setting. As I said, that's essentially mirror image for the beta blocker, that the class 1 indication for beta blocker is an outpatient beta blocker. In those patients, you want to make sure they continue to have their beta blockade maintained perioperatively. Outside of this class 1 indication, the guidelines are a little bit more encouraging of starting statins perioperatively. As a class 2A recommendation, it says perioperative initiation of statin use is reasonable in patients undergoing vascular surgery. And it says perioperative initiation of statins may be considered in patients with clinical indications according to guidelines more generally if they're undergoing elevated risk procedures. And if one thinks about it, the reason the guidelines are a little bit more enthusiastic about starting statins perioperatively is it's harder to cause harm with starting statins in the perioperative setting. We saw from the POISE trial that certainly starting large doses of beta blockers right before surgery without good dose titration, that actually hurt patients and increased mortality even as it reduced perioperative ischemia. In statins, there's really no parallel way that you're going to be harming patients by starting them. So, of course, I follow the class 1 indication that if they're on a statin, I continue them on a statin. But I'm fairly liberal with starting statins in the perioperative setting if the patient has another indication for the patient to be on a statin, or if they're undergoing vascular surgery. So I follow these either 2A or 2B recommendations, and if I can find a reason to start patients on statins perioperatively, I usually will, because we just saw from the DECREASE trial that trial, as did the meta-analysis, showed a significant benefit in statins to reducing the harder endpoints of perioperative MI and mortality. So turning our attention now to perioperative aspirin, remarkably, we actually didn't have a good large prospective RCT of perioperative aspirin until fairly recently. There was a study published in EGIM in 2014 known as the POISE 2 trial, which looked at the effect of aspirin given perioperatively. This was a large and I think very well-designed study in which there were 10,000 patients who were undergoing non-cardiac surgery who were at risk for vascular complications. Patients who were in the coronary stent critical periods who needed to be on aspirin and Plavix after a stent were excluded. The primary endpoint was death or non-fatal MI at 30 days. And the patients were stratified by whether they were already taking aspirin or not. So basically, there were patients who were not on aspirin who were started on aspirin. There were patients who were on aspirin who were stopped, whose aspirin was stopped. And then for the patients who weren't already on aspirin, some were continued off aspirin and some were started on aspirin. So basically 2x2 design. And there was no benefit overall to aspirin in the primary outcome or any of the secondary outcomes. The negative results were the same for both the continuation group and the initiation group. So for those who were started on aspirin de novo and for those who were continued on aspirin who were already on it, there was no benefit to aspirin in either the initiation group or the continuation group. Unsurprisingly, aspirin was associated with a increased risk of major bleeding. And starting on post-op day 8, there was no significant difference in the bleeding risk between the aspirin and the placebo groups. So here we see some of the, we see a visual representation of the results, and we also see the subgroup analysis. So to say that there's no benefit to aspirin overall, that's only moderately surprising to me. That the benefit to aspirin didn't appear to exist overall for all comers in the study. But what did surprise me is that aspirin wasn't of benefit in any of the subgroups, because you can imagine subgroups where you think perioperative aspirin may be beneficial, such as those undergoing vascular surgery or those with a particularly high RCRI score. And you can see there on the right in the subgroups, they looked at multiple subgroups, and in none of the subgroups was perioperative aspirin beneficial relative to placebo. So, that said, what is the clinical upshot of these data? So I certainly don't stop all my patients who are on aspirin going into surgery. The way this study has really changed my clinical practice is when I have the discussion with the surgeon over the risks and benefits of aspirin. So if a patient is on aspirin and the surgeon is comfortable that the bleeding risk even on the aspirin is low, then I'll usually still continue the patient on the aspirin. However, if the surgeon expresses some concern about the bleeding risk of the patient being on aspirin, prior to this study, I would dig in a little bit more and say, no, we really need to continue the patient on the aspirin. We can always transfuse them, and we need to accept that bleeding risk. Given the results of this study, I am a little bit more moderate in that position, and I'm more willing to hold the aspirin if the surgeon is concerned about the bleeding risk, given the inability of this study to demonstrate a significant benefit to aspirin perioperatively. So the bottom line here is aspirin was not beneficial in reducing 30-day death or non-fatal MI overall or in any of the subgroups analyzed. So one question that often comes up that I want to talk about for a moment or two is what should we do with the ACE or the ARB perioperatively? Because the AHA guidelines say not a lot of data, but there's no specific, the guidelines don't support holding the ACE or the ARB around the time of surgery. Published since the guidelines were released, this study was a prospective cohort study that looked at about 1,500 patients, about a third of whom were on an ACE or an ARB who were undergoing non-cardiac surgery. The primary endpoint was all-cause death, stroke, or MI after non-cardiac surgery at 30 days. And about a quarter of the patients had their ACE or ARB held. So one of the interesting things is when they looked at the patient characteristics of those patients for whom the ACE or ARB was held compared to those patients who had the ACE or ARB continued, they couldn't find any significant difference before the groups. So what that tells us is there's a lot of sort of local practice. Some areas they tend to hold it perioperatively, some areas they don't. But there's not a lot of differences between those patients for whom it's held or not held. So that really suggests it's sort of local practice rather than a clinically significant difference between the patients. So when they looked at the primary endpoint, which, as I said, was death, MI after surgery, or stroke, the primary endpoint was lower in the group who had the ACE or the ARB held compared to the group in whom it was continued. And if you look at the data there, that improvement in the primary endpoint was really driven by a decreased risk of MI after non-cardiac surgery, the MINS. So that was significantly lower in the ACE and ARB group, in the group for whom the ACE and ARB was held, compared to the group in whom the ACE or ARB was continued. And unsurprisingly, if you look at the rate of intra-op hypotension, the rate of intra-op hypotension was also lower in the group in whom the ACE and ARB was held compared to the group in whom the ACE and ARB was continued. So, so what my practice, and what I think these data support is, if a patient is on an ACE and an ARB for, let's say, blood pressure control, and their blood pressure is reasonably controlled in the hospital, then it is reasonable to hold the ACE or the ARB around the time of surgery, given that the rate of MI after surgery and intra-op hypotension seems to be lower in those who have the ACE or the ARB held. If the patient is on the ACE or the ARB for a reason beyond blood pressure control, if they're on it, let's say, for CHF, in those patients, I tend to continue it because this study wasn't able to analyze the patients by subgroup. And I certainly have a concern if you're going to take the ACE or the ARB off around the time of surgery, they're going to get a lot of fluids around the time of surgery. Typically, I'm concerned about tipping them over into CHF. So if they're on it for reasons of CHF, I'll typically continue it. If they're on it for blood pressure control and their blood pressure is pretty well controlled in the hospital, then it's I think reasonable to hold the ACE and the ARB in those patients. So now bridging anticoagulation. There is a important trial that I want to mention that has sort of shaped our practice when it comes to bridging anticoagulation, and that is the BRIDGE trial, which randomized about 1,900 patients with AFib who were on Coumadin, who were scheduled for elective procedures, and they're randomized to either bridging anticoagulation with low molecular weight heparin or placebo. Patients had to have at least one of the CHADS2 risk factors, and the mean CHADS2 score was 2.3. So this is just sort of the study scheme, and what you can see, the details aren't super important, but the highlights are the warfarin was held 5 days prior to surgery. 3 days prior to surgery, the patient was started on either the low molecular weight heparin or the placebo, and then sort of 24 to 48 hours after surgery, they restarted either the low molecular weight heparin or the placebo, and also started them on warfarin. And what we see in terms of the results are for the primary outcome, which was risk of arterial thromboembolism, there was no difference between the bridging and the no bridging group. So those who were bridged did not have a significantly lower risk of strokes and thromboembolic events. The other primary endpoint was major bleeding, and unsurprisingly, the rate of major bleeding was higher in the group. You can see almost threefold higher in the group that received the bridging anticoagulation. You also see the rate of minor bleeding, which is one of the secondary endpoints, was almost, was close to being doubled in the bridging group compared to the placebo group. So of course, having the patients on bridging anticoagulation increases the risk of bleeding, but doesn't increase the risk of thromboembolic events. For those of you who sort of have a keen eye and we're looking at the secondary endpoints, one thing which jumps out at you a little bit is the rate of MI. So the rate of MI was roughly double in the bridging group compared to the group that wasn't bridged. This at first seems a little counterintuitive, because if we're using more therapeutic anticoagulation, you would think that would decrease the risk of MI compared to less anticoagulation. But what seemed to occur in this study is when you have a risk of major bleeding, or when major bleeding occurs, and as we see, the risk of major bleeding was higher in the group that was bridged, the acute anemia that comes along with the major bleeding, that can also induce ischemia. So that seems to be the effect that was occurring here, is the major patients were basically having MIs due to acute anemia from the major bleeding as a result of being on the bridging anticoagulation. And that seems to have driven the increased rate of MI in the bridging group compared to the non-bridging group. So, so for patients, patients who are sort of low to moderate risk with a mean CHADS2 score, in the 2 to 3 range, this study supports not bridging them. One frustration with this study is it doesn't provide us a good answer about what to do in the patients who have a really high CHADS2 score. So what if their CHADS2 score is 5 or 6? Now we tend to use the CHADS2 VASC score. So, if you have a CHADS2 VASC score and, the 6 or 7 range on the higher end, should we bridge those patients? This study, unfortunately, didn't answer that question. You can see here, there was only a small number of patients at the higher end of the CHADS2 score distribution. And for that reason, the study was underpowered to identify any difference in thromboembolic risk for those who are at really elevated risk, so with very high chance 2 scores. So, at least my practice and the practice that I observe locally is we still do bridge some patients who are at very high risk, who are at higher risk than the patient population in this study. That high risk population, it is still appropriate to seriously consider bridging them. So the bottom line is, in patients with a mean CHADS2 score of 2.3, perioperative bridging anticoagulation does not reduce the risk of thromboembolic events. Given that we're seeing so much more DOAC use as therapeutic anticoagulation in our AFib patients, that sort of takes the bridging question out of the equation, because in patients who are on DOACs, they get out of your system fairly quickly, so we can stop it typically 2 to 3 days prior to surgery, and giving the relatively quick on and quick off. Usually bridging anticoagulation is not a consideration for most patients. And I wanted to put up this figure just because it provides some helpful guidance as to when you want to stop the DOAC prior to surgery and when you want to restart the DOAC. So I'm not going to sort of go through all the different DOACs and all the different scenarios, but I wanted to sort of show this, if nothing else, as a bit of a reference slide, as a thoughtful approach to stopping DOACs prior to surgery and then restarting them, in our patients who are on the DOACs for AFib. So now I'm going to turn our attention to perioperative pulmonary complications. Perioperative pulmonary complications are often given less attention and are often less interesting to a lot of us who do perioperative medicine, including me, partially because we don't have that many interventions to reduce the perioperative pulmonary risk. So we're good at identifying risk, but absent a lot of interventions to reduce that risk, identifying the risk becomes less sort of clinically important. That said, it is worth thinking about pulmonary risk, because perhaps secondary to cardiac risk, but still an important risk factor, and one that it behooves us to consider when we're performing a perioperative evaluation. So here we see that there are a bunch of perioperative pulmonary risk scores. You see one there on the left. Most of those are fairly intuitive. So this looked at almost 6,000 patients at 63 centers. Pulmonary complications were defined as either respiratory infection or failure, bronchospasm, atelectasis, pleural effusion, pneumothorax, or an aspiration pneumonitis. And you can see, based on your score, you're able to stratify patients into high, medium, or low risk. So as I said, most of the risk factors that you see in the table there are intuitive. Age, have they had a respiratory infection? What is their preoperative oxygen saturation? One that I want to highlight, because it's both very, very important in terms of the magnitude of the effect, and one that may be a little less obvious, is the site of the surgical incision. So the closer the surgical incision is to the diaphragm, the higher the pulmonary risk. Which, if one thinks about it, makes sense, because if the surgical incision is close to the diaphragm, then taking a deep breath is going to be very, very painful. And if taking a deep breath is very painful, you're going to get more atelectasis, and with more atelectasis, you're at higher risk of pneumonia and other pulmonary complications. So that's sort of probably the mechanistic chain by which having the surgical incision be close to the diaphragm puts you at higher risk. But that is a very important risk factor to bear in mind when considering pulmonary risk. So one of the interventions we do have available to reduce the risk of perioperative pulmonary complications are lung expansion maneuvers. So in patients at elevated risk, such as those undergoing abdominal surgery, a lung expansion maneuver is appropriate, and it's more effective than no intervention. Options include incentive spirometry, lung expansion exercises, and continuous positive airway pressure, or CPAP. So there's no compelling evidence that favors one lung expansion intervention over another. One lung expansion maneuver that I actually find helpful and I use in my practice is what I call an artificial yawn. The reason yawning probably evolved in humans is as an anti-atelectatic mechanism. So when we're tired, we may take less deep breaths, we may breathe less frequently, and that puts us at risk of atelectasis. So a yawn is that lung expansion that opens our lungs and reduces atelectasis. And patients understand what a yawn is. So for my patients who are at elevated pulmonary risk, particularly if their mental status is very sharp after surgery, I'll encourage them to do an artificial yawn, and let's say every half hour, as a way to keep their lungs expanded. And if there's a family member in the room, I'll say, remind them every half hour, all take a good yawn together. And that, my hope is that that is an effective anti-electatic maneuver. It is lung expansion exercise, and it is certainly low cost and low risk. And CPAP may be appropriate in patients who are unable to undergo either incentive spirometry or lung expansion exercises. And CPAP is especially advisable in OSA patients. So smoking cessation. My discussion here of smoking cessation is mainly for those of you who are taking the board soon. So smoking cessation, it may help reduce the incidence of postoperative pulmonary complications if one reduces smoking a few months before surgery. There are actually a couple of studies that suggest quitting smoking, let's say 1 month or 1 to 2 months before surgery, may actually be associated with an increased risk of postoperative pulmonary complications. This matters for those of you who are taking the boards. So if you're doing your recertification exam and they're saying, what do you recommend to this patient who's undergoing surgery the next day? The right answer is to continue the beta blocker or continuing the statin. The right answer isn't to stop smoking. Given that we have this little bit of information, or given that we have two studies that suggest that quitting smoking, in the week or two before surgery, may be associated with increased pulmonary complications. In real life, if my patient's motivated to smoke, I'm always going to encourage them to smoke, but at least those are what the data tell you, which I think, as I said, is only really relevant when it comes to standardized testing. The anesthesia techniques also need to be considered. So, long-acting neuromuscular blockade, such as with pancuronium, given that it can have some residual weakness, that is associated with increased risk of postoperative pulmonary complications. And up until recently, we didn't actually have good data on this. We now more recently do have some studies that confirm what we expected, which is using spinal or epidural anesthesia as compared to general anesthesia can also reduce the incidence of postoperative pulmonary complications. That actually can be a really important point, because when one's thinking about, let's say, a patient who may have advanced COPD, who's on oxygen at home, who, let's say, really needs surgery, the prospect of putting them on a ventilator for surgery can be very worrisome, because you're always concerned, are you going to be able to get them off the ventilator given their severe underlying pulmonary disease? In those cases, it's really worthwhile having a conversation with your anesthesiology colleagues to say, can this procedure be done not under general anesthesia? I've been consistently impressed with the ability of my anesthesiology colleagues to do a wide variety of procedures, not under general anesthesia, under regional anesthesia, if it's really important. There's even been a small number of patients who've had to have their hip fractures repaired that we've been able to do under not under general anesthesia, under spinal anesthesia, because we were very, very concerned that their underlying lung disease would prevent us from getting them off the ventilator. So in patients who are at high pulmonary risk, that's really an important conversation to have with anesthesia, which is, do we need to put the patient under general anesthesia to begin with? So now I'm going to finish up with sort of a bit of a potpourri of a few sort of perioperative topics relevant to specific populations. So I mentioned before the hip fracture patients. The key thing to know about hip fracture patients is don't delay and don't dawdle. You can see there, this was a large retrospective study of over 40,000 hip fracture patients. And you can see when you look at the 30-day mortality, those patients for whom you wait more than 24 to 36 hours, and certainly if you're waiting more than 48 hours, those patients do worse in terms of their 30-day mortality. There probably is some confounding that patients who are sicker tend to have a delay in surgery. So while I acknowledge there may be some confounding in this data, there's other data that supports this. So for hip fracture patients, you want to get them to surgery really as soon as you can. So almost never is it appropriate to get a stress test in these patients. Often, in many of these patients, it's probably not worth the while to delay to get an echo. We really want to try to get these patients to the OR within 24 hours. And if you're delaying getting these patients to the OR, there just needs to be a really compelling reason. So for OSA patients, both respiratory and cardiovascular perioperative complications are more common in patients with untreated OSA than patients without OSA. And prescribing CPAP for patients with OSA, it reduces, actually the main study that looked at it showed that it reduced cardiac complications, but not pulmonary complications. But that said, it's really important that patients who have OSA, that they get their CPAP in the hospital. I also spend some of my time in the patient safety space, and I've seen definitely a handful of cases where patients use CPAP at home for their OSA, and because no one thought about it, it wasn't continued in the hospital. And when that happens, that's really an unforced error that can be very hard to justify. Because if you think about someone's at increased risk of, let's say, hypoxia due to their OSA and their body habitus, you add in them being sedated after surgery, getting pain medicines to manage their perioperative pain, and the cumulative risk of a pulmonary complication is going to be elevated. So not taking a intervention that we expect to reduce that risk, which is continuing their home CPAP, is, as I said, really an unforced error. So that's sort of a detail that it behooves us to be attentive to. And then for obese patients, obese patients, one complication that obese patients seem to be especially at increased risk of is post-op rhabdomyolysis, which, if you think about a patient, being on the surgery table, the stainless steel table for 3, 4, 5 hours, when they're markedly obese, it's not that surprising that there's going to be a risk of rhabdomyolysis. So particularly for your obese patients who may have had a longer duration of surgery, if they have post-op AKI, you want to think about rhabdo, and you want to think about checking the CK, because if it's AKI driven by rhabdo, that's very treatable. Of course, hydrate them aggressively, so that's a cause of post-op AKI that we may not want to think about, but we want to make sure that we don't miss. So obese patients also can have restrictive lung physiology, and so those are patients for whom you want to consider CPAP. And as I said, if they're on CPAP at home, please definitely make sure that CPAP gets continued in the hospital perioperatively. So frailty, this is actually one of the sort of newest areas that is starting to get traction in the perioperative literature, which is the importance of frailty. You see there's the Fried Frailty Index. I find all the frailty indexes a little bit cumbersome to operationalize. For instance, the Fried Frailty Index asks you to measure their grip strength. So yeah, I said I think that limits its use of specific frailty indexes in practice. However, a lot of us sort of have a gestalt idea of frailty, and what the data show us is that frailty is an independent, I should say, independent risk factor for adverse outcomes in the perioperative setting. So here you see on the left, it's ASA class. That's the ASA class, American Society of Anesthesiologists class, which is basically a scale of how sick the patient is or what their level of systemic disease is. And when you add a measure of frailty to the ASA class, you get a better ability to predict if that patient is going to be discharged to a nursing facility. And similarly, on the right there, you see a measure of what they say Lee alone, that's the Revised Cardiac Risk Index. And when you add frailty to the RCRI, you also get better ability to predict if the patient is going to need to go to a skilled nursing facility. So I think the reason this matters is that when you have your sense of frailty, the data show us that in our frail patients, that is a risk factor separate and above whatever risk we've identified through, let's say, the NSQIP calculator or the other risk measurement tools that we use. So frailty is important. And I think this is actually an area where we're going to see a surge of literature or a surge of studies in the perioperative literature, because this is an area that we're seeing a lot more focus on. This also drives some of what we're seeing in terms of having geriatricians co-manage patients perioperatively. So yeah, this is a really important area to think about. So now to finish, we have a couple of multiple choice questions. So I'll read this and then pause so that you can think about the answer. So you are asked to perform a pre-op evaluation on a 71-year-old female who has a history of hypertension, diabetes type 2 on metformin, hyperlipidemia, and osteoarthritis, who is scheduled for a left knee replacement tomorrow. Physical exam is unremarkable. Medications include metformin, amlodipine, and atorvastatin. I should also say if you put her into the NSQIP calculator, you're going to get a MACE risk less than 1%. So which of the following is the most appropriate recommendations for the patient? Do you want to start her on atenolol? Do you want to continue her atorvastatin? Do you want to start her on aspirin? Or do we want to get either a preoperative nuclear or preoperative EKG stress test? So I will pause a moment for you to think about it. So in your mind, circle the answer which you think is correct. So for this answer, the correct answer is B. The patient should be continued on her atorvastatin in the preoperative period. As we talked about, the major class 1 recommendation for perioperative statin use is if the patient is on a statin as an outpatient, you want to continue the patient on a statin perioperatively. That was the case here, so this patient should definitely be continued on the statin. When we think, it's also important to think why the wrong answers are wrong. So we wouldn't want to start the patient on a beta blocker because from the POISE-2 trial, we know that starting patients on a beta blocker right before surgery has the potential for harm. We also mentioned the AHA guidelines make that as a class 3 recommendation that you do not want to start, you should not be starting beta blocker within the 24 hours around the time of surgery. The POISE-2 trial, which looked at aspirin, showed us, perioperative aspirin, showed us that there was no evidence to support a recommendation to start aspirin preoperatively. So answer C, which was to start aspirin, is incorrect. And as I mentioned on the question STEM, which you probably intuited, this patient's MACE risk is less than 1%. It's pretty low at 0.1%. So there is no indication to get a preoperative stress test in this patient, regardless of modality. So no indication for either an EKG or a nuclear stress test in this patient. So now turning to question 2 here. So we have a 74-year-old male who's being admitted in 2 days for a right total knee replacement. His past medical history includes OSA on CPAP, obesity, hypertension, and chronic kidney disease. His MACE risk is 0.7%. And outpatient medications include amlodipine, simvastatin, and atenolol. So which of the following is the most appropriate recommendation in this patient? The patient's beta blockers should be held to avoid intraoperative hypotension. The patient should undergo a preoperative nuclear stress test. The patient should undergo a preoperative EKG stress test. The patient should continue his CPAP while he's in the hospital, or given the patient's cardiac risk, the surgery should be canceled. So I'll give you guys a moment to consider which answer you think is correct. So the correct answer here is D. The patient should continue his CPAP while in the hospital. As we talked about, perioperative CPAP in OSA patients has been found to reduce cardiovascular complications. So if the patient is on CPAP as an outpatient, you definitely want to make sure that you continue the patient on his CPAP as an inpatient. So continuing the patient's beta blocker perioperatively and those who are already on it is a class 1 recommendation. There is no reason to stop the patient's beta blockers. As you know, that's the opposite of what we want to do. We should continue it. With a MACE risk of less than 1%, the patient is considered not at elevated cardiac risk. And so there is no indication to have the patient undergo a stress test, either EKG or nuclear. And with that low cardiac risk, there is certainly no indication or no reason to suggest canceling a surgery due to the cardiac risk, which is not elevated in this case. So, so those are our 2 multiple choice questions. Here's the last slide. We have some references, and I want to just end by saying thank you very much for the opportunity to discuss this area, and thank you for taking the time to listen to my presentation. Thank you.